Hello and welcome to Convent House Pathology for the second part of the first lecture on introductory pathology, which forms part of the movement and musculoskeletal biology course for students of UCL. In the first part of the lecture we looked at inflammation in general, the cells involved, and some definitions of terminology used in describing the inflammatory process. As promised, in the second part we consider some specific examples of inflammation in relation to bone and joint, particularly infection, mechanical trauma, crystal deposition, and flare-ups of chronic arthritis. Here we have a red-hot swollen knee. It's showing the cardinal signs of inflammation, which were covered in the first part of the lecture: rubor, tumor, calor, dolor, and functio later. It's red, it's hot, it's swollen, it's tender, and it's lost its function. There are several possible causes of this, including local trauma, but the most likely would be infection. Other possibilities include deposition of crystals, gout, and pseudo-gout. In order to investigate the problem, one approach is to aspirate the knee, put in a needle, withdraw some fluid, and examine it under the microscope. If the knee is inflamed due to infection, we would expect to see acute inflammatory cells. If the problem is one of crystal deposition, we would, of course, expect to see crystals. Here in the next slide we can see some urate crystals characteristic of gout. They're long and needle-like, and they show classic birefringence, which means that when you look at them under polarizing light with a quarter-wave plate in the microscope, some of the crystals appear blue, and the ones that are at right angles to those will appear yellowish-orange. The morphology and the characteristic birefringence are diagnostic of gout. Gout then is due to physical trauma. The crystal, as seen here in this scanning electron micrograph, is actually inside the cell. It's a disease whose signs and symptoms are due to irritation of the tissues by the deposition of monosodium urate crystals. Gout is a disease of higher primates, such as ourselves, because we, characteristically, lack the uricase enzyme that deals with sodium urate. The crystals trigger a local inflammatory reaction. When the crystals form a mass, it has a characteristically chalky appearance. This mass is known as the gouty tophus, T-O-P-H-U-S. And the classic place for a tophus to be deposited is in the first metatarsophalangeal joint, or the interphalangeal joints of the great toe. The gout sufferer is famously depicted as an aristocratic middle-aged male with his foot up on a gout stool, suffering the agonizing, stabbing pains of that condition in recompense for a life spent in debauchery and self-indulgence. The crystalline deposits of urate are radio-opaque, and here we can see them on an X-ray of the foot. Gout is a disease with a genetic component. Around half of gout sufferers may well have a family history, and this is due to genetic variation in urate metabolism. Gout is also commoner in men, not just because they tend to enjoy a richer diet, particularly including beer and port, drinks notorious for producing gout, but also because of genetic factors. Obesity also plays a part. Again, it's a sign of rich living, but also the higher the body mass, the more purine there is to metabolize, and the more likely urate is to build up in the tissues. The association of gout with alcohol particularly involves beer, by which I mean proper beer, not anemic lager, which is not capable of inducing anything, and also port. Sadly nowadays, port is sometimes not served after dinner, or perhaps even worse, it is served but is of an inferior quality, something that could never happen here at Convent House. A further risk factor for the development of gout is chronic lead poisoning, again much commoner in the past when domestic paints and even the paint on children's toys contained lead. What foods contain purines? Well, I'm glad you asked that, and the short answer is the nice tasty ones. Here, for example, is a sample menu for a purine-rich meal. When was the last time you tucked into anchovies, brains, kidneys in gravy, liver, sardines, sweetbread, oysters, venison, lobster, tripe and calves' tongues? Presumably it wasn't breakfast. Sweetbreads, incidentally, are endocrine glands such as pancreas and thyroid, not, as some people seem to believe, gonads. If all that hasn't made you too hungry, let's move on to acute flare-ups of rheumatoid arthritis. Rheumatoid arthritis is sometimes called rheumatoid disease to emphasize the fact that it's a systemic autoimmune disease. In the joints, flare-ups are characterized by the signs of acute inflammation that we've already covered, and the presence of inflammatory cells, particularly in rheumatoid arthritis, the plasma cell. That's the one with an eccentric nucleus that's supposed to look like a clock face and a Golgi apparatus that's sufficiently prominent to make it resemble a fried egg. Here we see a pair of arthritic knees. One way of distinguishing arthritis from local inflammation is, of course, that arthritis tends to be symmetrical, whereas inflammation will only involve one joint. The same is true of gout, it's rarely symmetrical. Here's a knee that we split open earlier in the days when autopsies were a little more extensive than they are now, the days before the Human Tissue Act. So this is a knee that's been opened up, and you can see that on the left is the top of the tibia, and at the right are the inferior femoral condyles. Rather than being smooth and shiny, as they should be, they have an irregular bread and butter appearance. You can readily appreciate, therefore, that during life the joint was somewhat sticky, reduced in movement, and when it did move, that movement was painful. You can also perhaps appreciate that in contradistinction to osteoarthritis, the more the joint moves, the easier it gets, as it begins to unstick and the surfaces acquire more lubrication from the synovial fluid that passes across them. Here's a summary of some of the cells and the immune processes involved. We consider synovial joints more in the lecture on arthritis, which is in degeneration and senescence. However, the type 2 synoviocyte is essentially a macrophage and is doing its best to ingest any particulate matter that's found its way into the joint space. Plasma cells accumulate in the synovium, often in groups, giving a characteristic histological appearance. Here we see a microscope picture from an arthritic joint. At the bottom you can see the partially eroded articular cartilage, and at the top is some inflammatory material which, in the situation of arthritis, is known as pannus, and is basically a collection of neutrophil polymorphs, plasma cells, and other acute and chronic inflammatory cells. Septic arthritis is, of course, due to inflammation. It typically involves only one joint and will follow trauma, particularly penetrating injuries, although will sometimes occur apparently spontaneously. In order to diagnose it, aspirate the joint, microscope the fluid, and send some to microbiology for culture. Care must be taken to do this using an aseptic technique, because the last thing you want to do is introduce inflammation into a joint that didn't already have it. What you would expect to see, apart from any organisms themselves, which would normally be bacteria, are acute inflammatory cells, neutrophil polymorphs, and macrophages. This should be an easy diagnosis to make because in a normal aspirate there should be no neutrophil polymorphs at all. That concludes the introductory lecture on the pathology of inflammation, which is part of the movement and musculoskeletal biology module. In the next lecture we'll consider neoplasia, happily avoiding its genetics, but looking at the pathological appearances and considering the terminology and nomenclature of that condition. Thank you.